Specifically for our type of residency, we focus on the underserved. So, and that tends to be a very vulnerable group who tend to miss a lot of prevention care, who, because they don't have access, they don't have coverage, they don't have financing to get where they need to go. There's so many barriers to care that the underserved populations have that we focus on how do you take down those barriers and help to improve the health care in that specific population. And that also goes a far way in reducing the expenditure of health care.
It's emblematic of our whole set of thoughts about, it's really a patient-centered approach. It's a patient-centered organization. And as we build and take it's patients in the middle. And again, an engagement team just focused on listening to patients and trying to shape what we do to really match.
In the Affordable Care Act, federally qualified health centers got $11 billion more of funding. Right now, federally qualified health centers receive $15 billion annually from the federal government. In Illinois, there are over 429 service delivery sites for federally qualified health centers. And so a lot of that additional $11 billion is going to be sort of transferred into the state of Illinois specifically.
The state will actually give a large grant. It gives a large grant to 39. In many cases, it can be up to about 70% of their operating budget.
Oh, wow. Okay.
So that's why I think hospitals and FQHCs are willing to support this model, is because they're not incurring the entire cost of what it takes to run one of these clinics, which can be between $200,000 and $400,000 a year. So it's not cheap, but it's very effective because they provide a lot of preventive care and chronic care management like asthma and diabetes, so that they can see students so that they're not in the emergency room or hospitalized.
Also, under currently Medicare, if you are a Medicare patient, you don't get any real preventative visits. Everything has a diagnosis to it. So there isn't really a focus on preventative care, making a plan for your preventative care. And under the ACA as it's written now, or it was written as, I haven't seen it like today, but the official, but no one knows what that's going to look like. But that at least once a year, or people on Medicare can finally get preventative visits, which they couldn't get before, and that would be something we could bill for and get paid for. Whereas right now, we see Medicare patients, we usually have something that we're diagnosing rather than being able to see people who may have Medicare but may not have a medical problem, but we want to do preventative care for.
Physicians feel more secure practicing that. Not that it changes. It changes in a way that you really practice medicine. You don't practice anything else. You don't do defensive medicine. You still are. Like the core elements of practice. You still use your skill set, your knowledge, and everything to treat patients, protect patients, prevent them from diseases. But at the same time, you feel a little bit more secure.
I like to think that if we were truly patient-centered, we would offer something to our patients that was compelling and let them navigate around issues of convenience and other habits of the heart. That's my answer. I'm sticking with it.
I think the idea of a medical home makes a lot of sense in terms of the fact that they're getting both mental health and primary care services on site, and they don't have to necessarily coordinate with any other kind of practitioners.
The journey to wellness, it transpires in relationships. And the better that's coordinated, the better. However, I also think we are creatures of convenience, and I think we also are able to discriminate in some cases about when we need to use those vital relationships to answer critical questions, and when we can supplement with dip into Walgreens and dip into somebody like around the corner because I need a strep test. And I'm not going to drive the 40 miles. But when I'm really questioning, do I have a chronic illness and how do I think about it? I'm going to go back where the heart is. And I actually think, and then there's convenience and wait time and, is it close to my office or close to my home? There are just so many issues. We have patients who are treated for addictions or HIV. They might want to explicitly go out of their communities and go and be seen somewhere else.
It's challenging because even with our patients with Medicaid or Medicare now, it's not always easy to find specialists that can take them just because the reimbursement rate is so low. My understanding with healthcare reform is there's going to be a certain amount of requirement for folks to take at least a small percentage of people that fall under this coverage issue, and we'll see how much of it shakes out.
Healthcare reform offers one incredible promise, and that's that people in this country will have some health insurance, or many, many more will have some health insurance. I think what that insurance buys, what purchasing power that confers to those patients is yet to be seen. But for an FQHC, where we have a large cohort of uninsured, and I will argue larger than any other private entity, certainly in the state, but I would argue, find me another one that has a cohort of 50 to 60,000 patients in any one year who come to us who are low income and uninsured. It's a very unusual mission that we've chosen, an unusual set of priorities because it's expensive. How do you take care of 60,000 people and buy Epic? And as I said, it doesn't leave us a lot of reserves for other things. But if those 50 to 60,000 patients were dropping a little bit more in terms of revenues, we could do a little bit more.